Thank you, Dr. Abdulaziz. Good morning, everyone. And again, I would like to thank the faculty member for inviting me to this important event, actually, which represents a great opportunity for all of us to keep ourselves updated in the medical fields. Today, I will be talking about IBD management, and I guess you have been dealing more frequently with IBD patients in the past few years. So I hope this is going to be a chance for all of us just to have a look on what's new in the field. IBD, as you know, is a consequence of an impaired dialogue between gut microbiota and predisposed hosts, leading to inappropriate activation of the immune system and hence chronic destructive inflammation of the whole GI tract in case of Crohn's disease and in the colon in case of ulcerative colitis. IBD actually takes place in the most educational and economical productive age, 15 to 40. First case of ulcerative colitis was reported in UK, 1859, around 60 years after the Industrial Revolution by Walter Wilkes. 100 years later, first case was reported in China. And since the first case in UK, the incidence rate of IBD has been increasing in both Western world and the newly industrialized countries. In UAE, the incidence rate is estimated between 0.3 to 0.5% of the general population. In Rashid Hospital, for example, we have IBD Center of Excellence, contains around 600 IBD patients, majority of them UAE nationality. The first case of Crohn's disease reported or described by Beryl Crohn in 1932. In 1955, the first randomized controlled trials published by Truelove showed the efficacy of corticosteroid in treatment of IBD. 57, first optical scope. 77, invention of 5-AZA as the active component of sulfasalazine. And in 1995, invention of infliximab as the first star in biologic era. Rectal involvement rate in adult ulcerative colitis patient is 100%. And if it's only rectum, it's E1 according to Montreal classification. If left-sided, it's E2. Any inflammation proximal to the splenic flexure, it is E3. Crohn's disease, either small bowel, mainly terminal ileum, but could be extensive disease of the small bowel, could be colonic, or could be both, small and large bowel. In rare cases, it can hit only the foregut, esophagus, stomach, and duodenum. The burden of IBD is immense, as you know. Young patients, around half of them are either in partial or no response to current treatment. Around a third of the patients have reported delayed diagnosis for at least 1 year since the beginning of their symptoms. Around 20% with anxiety, sleep disorder, depression, and around 10% with extraintestinal manifestation. This extraintestinal manifestation, as you know, is a wide range, includes oral ulcers, uveitis, iritis, episcleritis, erythema nodosum, pyoderma gangrenosum, spondyloarthritis, ankylosing spondylitis, renal stones, peripheral arthritis, primary sclerosing cholangitis, autoimmune hepatitis, pancreatitis, and perianal disease. And not only that, IBD patients are more likely to face another health challenges, like nutritional disorders, obesity, diabetes, cardiovascular disease, and risk of colorectal cancer. So in one sentence, IBD impacts every aspect of patient life. It affects the mental health, ability to work, social and sexual life. And here comes the importance of early diagnosis and early intervention. I think majority of you are aware of the IBD red flag index, which was designed to identify patients who may have IBD and who should be referred as soon as possible to GI specialty. Because we know for sure in multiple studies that delayed diagnosis is associated with high risk for early surgery and development of other complications. But if we can intervene as early as possible in advanced therapy, we may be able to change the course of the disease. The IBD course disease usually evolves, as you know, with flare-ups, followed by periods of clinical remission. But ongoing mucosal inflammation in ulcerative colitis and transmural inflammation in Crohn's disease. So in Crohn's disease, the ongoing inflammation evolves to fibrostenotic strictures, which unfortunately irreversible lesions, and could evolve to penetrating lesions like perianal abscess, fistulas, which require surgery. And even after surgery, if there is no medical intervention, the cycle is going to start over. In case of ulcerative colitis, the persistence of inflammation leads to motility dysfunction, narrowing of the colorectum, and risk of cancer and surgery. But if we could intervene in the first 3 to 6 months of beginning of diagnosis, we can be able to change the whole course of the disease. And once we establish the diagnosis, we stratify patients based on risk factors. And we do that to select patients who need for advanced therapy and to spare patients who don't. So the shared high-risk factors in both Crohn and ulcerative colitis are extensive disease and severe endoscopic activity. In Crohn disease, age at diagnosis less than 30, perianal or severe rectal disease, stricturing or penetrating behavior, and history of surgical resection. In ulcerative colitis, age at diagnosis less than 40, high CRP, steroid-dependent disease, history of hospitalization, and superimposed opportunistic infection. Next step is to define our target from treatment. And actually, in biologic area, the goals of IBD treatment has been evolved dramatically from clinical response to clinical remission, biochemical remission, endoscopic remission. Lately, we started to talk about histologic remission in ulcerative colitis and transmural healing in Crohn's disease. And still, we have hope to reach the point of molecular clearance. But at least, nowadays, we have to achieve the endoscopic remission. And why that? Because we know for sure in multiple studies that endoscopic remission is associated with low risk for surgery, for failure of medical treatment, and for hospitalization. So we follow usually treat to target strategy, which is a journey of ongoing and regular observation of the target, with escalation of treatment or maybe switch to another class if the target is not met. And of course, we do our best to tailor all of these components to the needs of the individual patient. So what weapons do we have to face IBD? We have 5 ASA for ulcerative colitis, corticosteroids, immunosuppressant, biologic agent, small molecules, and the corner we try our best not to reach to, which is surgery. Corticosteroid, as I mentioned earlier, since 1955, the first study published by Trulove, we know that corticosteroid is very effective and have a fast onset of action to deliver a clinical remission within 5 to 7 days. But the same studies, just keep in mind, have showed and confirmed corticosteroid are ineffective maintenance agent for IBD. So regardless of the side effects of the long usage of corticosteroid, it is only to induce the remission, not to maintain it. Immunosuppressant, we have sufficient data, as you know, for thiopurines, Imuran and 6-MB, for methotrexate, this data for cyclosporine and tacrolimus. Biologic agent and small molecules, we have anti-TNF since 1998, started with infliximab, golimumab, adalimumab, citralizumab. Anti-integrin in 2014, we have vedolizumab, anti-interleukin 12-23 antibodies. We have ustekinumab in 17 for Crohn's and in 19 for ulcerative colitis. JAK inhibitors, we have tofacitinib, which is pan-JAK inhibitor, started in or approved in 2018. And in 2022, we have 2 new agents, obadasitinib and filgotinib. Anti-interleukin 23, this is a new class. We have risankizumab, we have giselkumab, and we have mirikizumab and etrolizumab. The other new class is S1P modulator. We have 1 agent for treatment of ulcerative colitis, which is ozanimod. How about antibiotics? Just keep in mind, no role for antibiotics, neither to induce or to maintain remission IBD. So guys, we have to change the practice of prescribing Cipro and Flagyl for all the IBD patients who presented to emergency with flares. Don't give antibiotics unless you have 4 indications. You have pouchitis, you have perianal disease, abscesses, or superimposed infection. Other than that, no role for antibiotics. Let's have a look on the latest guidelines update from ECO regarding Crohn's and ulcerative colitis. In Crohn's disease, mild to moderate disease, usually we use budesonide. And again, guys, no more 5-ASA in treatment of Crohn's disease. 5-ASA only for ulcerative colitis. Forget about 5-ASA and Crohn's disease. In moderate to severe active disease, we have a lot of options. Corticosteroids, we have anti-TNF. If we started infliximab, better to combine it with thiopurines or another immunosuppressant. We have anti-interleukin 12-23, ustekinumab, we have anti-integrin vedolizumab. In case of medical failure, we refer the patient for surgery. How to maintain the remission in Crohn's disease? Simple. Apart from corticosteroid, just continue with the same agent that could induce the remission. In perianal fistulizing disease, infliximab is preferred, plus minus immunosuppressant. We don't have enough data to recommend for usage of vedolizumab or ustekinumab in perianal fistulizing disease. And again, antibiotics not alone. In ulcerative colitis, mild to moderate disease, oral 5-ASA, plus minus topical, but oral and topical preferred or superior to oral only. Topical steroid is an option as well, but topical 5-ASA is superior to it. In case you need corticosteroid in ulcerative colitis, go for budesonide MMX, which is colonic release corticosteroid. How to maintain it? Oral 5-ASA. In case of distal disease, you can go for topical 5-ASA, for example, in case of proctitis. And in case of intolerance to 5-ASA or disease gets steroid dependent, you can think about thiopurines. In moderate to severe ulcerative colitis, same options like Crohn's plus anti-JAK. So anti-JAK only for ulcerative colitis so far. How to maintain the remission? Again, same rule. Just continue with the same agent that could induce the remission. In case of acute severe ulcerative colitis, which is by definition a bloody diarrhea with signs of toxic or systemic toxicity, like fever, tachycardia, CRP more than 30, hemoglobin less than 10.5, usually we admit such patient to hospital to give IV steroid. Usually we give 100 hydrocortisone, 100 milligram TDS. Most of the cases will respond within 3 to 5 days. If no response, you have two options, either surgery or rescue therapy. Regarding rescue therapy, you are aware of two agents, infliximab and cyclosporine. Now, a new agent, tofacitinib, looks like a promising one. It succeeded in one study published in 2022 in 4 cases of acute severe ulcerative colitis. So it's possible to join this group of rescue therapy in the coming future. If you induce remission with infliximab, continue infliximab. Tofacitinib, continue tofacitinib. Cyclosporine, you continue with thiopurines, not cyclosporine. And if rescue therapy failed, we think about surgery. Usually, the general indications for surgery in IBD, 2 options. Either failure of medical treatment, or you are treating complication of the disease. So indications for elective surgery in ulcerative colitis, for emergent surgery in ulcerative colitis, refractory severe ulcerative colitis, toxic megacolon, perforation, massive hemorrhage. Indications for elective surgery, as I said, failure of medical treatment, cancer or dysplastic lesions that are not removable with endoscopic intervention, and refractory severe extraintestinal manifestation. And this, I would like to thank you so much for your attention. Before time, Tahania.